Welcome to the Hernia Gods podcast. This is your mere mortal host, Luke Elms. The views, thoughts, and opinions expressed on this podcast belong solely to the hosts and guests and do not necessarily reflect the official policy, position, or opinions of Orlando Health or any of our employers. And now, without further ado, let's talk hernias. All right, thanks and welcome to another episode of the Hernia Gods podcast. This is your mere mortal host, Luke Elms. I'm joined today by one of the pillars of the hernia community, Dr. Conrad Ballecer, and he is joining us all the way from Arizona. It's a true honor and a pleasure to have you on, sir.
Yeah, Luke, it's the honor's mine. Thank you for the invite.
Yeah, we've got off to a fun start. Had Hernia on last time, and we're so happy to have you come on and talk. You know, I'm just now really entering into the broader hernia community. I've been what you may call it casual for a while, following on the IHC and things like that, but I rarely post, but I'm always just kind of lurking around. And so obviously I've known a lot about you and the other high traffic folks in the world. And it's been interesting to get to know kind of the people behind the scenes. And so again, so happy that you're here today. How about you start by just telling us a little bit about who you are, where you come from, your background.
Yeah, so born and raised Phoenix, Arizona, left a few times for school, but always gravitated towards coming back. My family's here. I finished my MIS fellowship that I did at South Carolina, Greenville, under the tutelage of Doctors Will Cobb and Carbonell, who were all, fellows of the GOAT, Professor Henneford. Came to private practice back to Phoenix in 2010, was in private practice for about 9 years, and then decided to make the big switch to academic surgery, teaching residents and medical students at St. Joseph's Hospital, Creighton, Phoenix.
So what was I think that is a fairly common shift that's happening more and more today throughout the surgery community, but what was really the trigger that led you to jump from the private world into the employed world and specifically even into teaching?
So I always wanted, I've always had a big passion for teaching. The original goal was I was going to be in private practice for 5 years. I didn't want to start teaching until I knew I was ready to give up the sticks, so to speak. Yeah. I didn't want to be one of those attendings that are going through my own respective learning curve while teaching. My passion for teaching was aided by the fact that I started performing robotic surgery, and I was able to train a lot of people. So the jump to academic surgery was longer than what I thought it was. I was approached by my current partner, Dr. Gillespie, in 2019, who actually offered me the job. They built a new medical school. They actually combined the program that I did my residency with another community hospital, and it became the Creighton program. And I wanted to be a part of that. So I was very lucky. It was right place, right time. Super happy about the switch too.
Yeah, the one thing that you mentioned there, I wish, this is something I wish I'd have heard earlier in my career. I'm in my 10th year, but it is really a struggle when you're trying to go through the learning curve of practice, especially right out of training, and then also even through that learning curve of new procedures or new techniques, and you're trying to teach. And so I spend a lot of my time feeling like I'm doing a disservice, but I'm really just trying to get through my own learning curve to get to the point where I feel competent enough to really teach them the correct way to do things. Do you have any techniques or tips for that?
For me, it was operate as much as I could. Private practice, I was super busy. I was on call in the beginning part of my practice. I was on call almost every other day. I didn't do trauma, but I did a lot of acute care surgery. I was fortunate to join a partner, Dr. Brian Preble, who was already very busy as not only a on-call surgeon, but also his elective practice was busy. So I fell into the perfect program where I could get through my learning curve relatively quickly through a high volume of cases and cases that span the gamut, everything from foregut to hindgut to everything in between. Certainly, hernia was a big part of my practice. That obviously was a big part of my training. So there were some facets of that I was able to bring to my hospitals here in Phoenix and help my partner out at the same time.
Did you make the jump? Did you make a full jump to hernia only at this point?
No, not at all. That was uh, somewhat of an unfortunate byproduct when joining academic surgery. I love doing all forms of surgery. I love doing colon. I love doing foregut. I love doing solid organ. Um, but in academics, it's so specialized, so I just don't see much of that anymore. All the colons go to colorectal. Most of the foregut goes to the Thoracic Institute, which is a big institute in my program. And we have an endocrine surgeon who does the solid organ stuff. It's funny because when I was talking with the chair at the time, doing my initial interview, I said I didn't want to be the hernia guy. And he said, "Oh yeah, you're free to do whatever you want to do,
Yeah.
but the reality is you only get to do what you're referred in my practice." And um, yeah, I kind of miss it. I kind of miss
Yeah.
doing everything else. So when I see something else, I get all excited about it. Like even lipomas, or I just
Yeah.
got a superficial temporal artery biopsy. I've never done one of those, but I'm super stoked. I'm sure I'm gonna go on YouTube right before that case and figure out how to do that.
Yeah, yeah, those are um, the program that we joined. I joined a really busy like community hospital, but the
Yeah.
emergency department sees upwards of 130,000 visits a year, and so
Mm.
it is very very busy on the acute side. And as I've become more and more, hernia driven, you start to lose some of those other procedures that you did. And
Yeah.
occasionally, and I've heard other people, it almost is kind of like hits at the core of you as a general surgeon when all of a sudden you start like giving up some of those things. So I was curious if when you obviously do a high volume hernia, if that ever, gave you pause that you may be losing out on other things that you had trained to do.
Oh, 100%. And um, probably one of my better qualities that's probably hurting me right now. I've never had the ego of like uh, doing everything that was out there, that everything that was referred to me. Back when I was training, they were saying, if you get a referral, you have to do that surgery. You can't give that up. I never thought that way. I always had the mindset, if there was somebody better that could do this surgery, I had no ego to hold that patient as my own. Currently, given like essentially, I do one surgery. I mainly focus on hernia, and within hernia, it's mainly the really complex incisional hernias.
Mhm.
So the other stuff, like before, for example, I do see some foregut patients. They're really complicated, though.
Mhm.
And I almost feel bad about doing those complex cases, even though that's what I did for 9 years when there's the Thoracic Institute at my next door, um, who clearly do it more often than I do right now. So, yeah, there's a lot of things that I'm just not really comfortable doing. Even straight stick chole, I went to Philippines for a medical mission, and I did some, but um, I don't do I don't do straight sticks anymore. Yeah, and I was going. I mean, I've done over 1,000 straight stick cholecystectomies in my lifetime. I'm sure I could have gotten through it, um, but even something like that, I just don't do.
Yeah, I feel the same way. I've been that way early in my career. There were times when the pressures, if you're being, if you're honest, the pressures of needing to grow because I was in a very competitive market and didn't have that kind of volume. Those pressures put you in a situation where at times you would do cases that you were capable of doing, but you knew that there was a specialist right down the road that does it all day long. And that's
Exactly.
one of the benefits of growth is that you're able to confidently say, I can do this, but this is who I would send my family to, and I think that's how I handle those situations now.
And I think at the end of the day, we're there for our patients, and
Hmm.
if I was a patient, I would want to be operated on by the best person that there
Right.
is available at that time. I think that's only fair. The unfortunate byproduct of that is uh, I don't do as much as I used to, nor am I
Hmm.
comfortable doing as much as I used to. Um,
Yeah. One
so
one of my biggest things here, we have a surgery center. We do straight stick choles there, but once you get used to doing robotic choles, then you're sitting there going, I can't see anything.
yeah,
It's
yeah,
you
I
get used
know.
to it, so
It,
it definitely is it's a completely different operation. Whenever
it's
I go to do it the other way.
Yeah, I mean it's painful. I remember the last straight stick Coley I did in my practice. It was 2015. The resident at the time I was teaching some residents would rotate, and the robot wasn't going to be available for a couple hours, and they were saying, "Let's just do the straight stick. It'll be fun." It was a 400-pound patient. It was gangrenous cholecystitis. It was literally one of the worst nightmares I've ever had. And I was like completely cursing out my resident after that. I said, "That's it. There's no way. There's no reason I'm gonna have to struggle like this." My back, I threw my back out. I bent some of the straight stick instruments. I was going, this doesn't make sense to struggle like this anymore.
Yeah, I try to selectively choose the right people to be done at the surgery center because it's not attached to a hospital, and
Yeah,
I'm just unable to predict. Like, I'm like, this person's had
exactly.
one episode of biliary dyskinesia, it shouldn't be a problem at
Yeah,
all, and like I get in
yeah,
there and it's just a disaster, and I'm like, how does this? And then I'll have that person's I've had pain every day for 3 months, and I take them in, it's
yeah,
pristine. I'm like, well, this was one I could have done laparoscopically, but
yeah.
when
And that's the thing. I never wanted to be one of those that said, "God, I wish I had the robot in this room right now." So,
sure.
um,
Yeah, that is
but yeah,
definitely
I
one of the
get it.
things.
The gallbladders are super unpredictable.
Hmm.
Um, I hold enormous respect for the gallbladder.
Yes.
That's one of the pathologies, given that it's so common, right?
Hmm.
They think there should be a perfect outcome every single time. The
Right.
reality is, in my opinion, these could be some of the toughest, most high stake procedures
Yes.
that's out there, right?
Yeah.
And no one is giving you a high five for taking out a gallbladder, right?
Yeah. Yep.
There's not a single person that's
No.
going to be impressed by you doing a laparoscopical
Yeah.
cholecystectomy. You can say, I did an IOC, I did, common bile duct exploration, and they're all, oh, yeah, well, wow, that's great. Yeah,
Yeah. You want a
yeah,
cookie? Yeah.
congratulations. Exactly. Want a cookie?
Yeah. No, I feel that way about gallbladders and ports. Ports for me are like
Yeah,
the devil. They either go as expected or horribly. There's no like winning when I place a
yeah,
port. You,
totally.
you get in a bad
Exactly.
one and it's like 2 hours long and they're like, this guy can't even do a port. And you're like, but it was like
Yeah.
central venous stenosis and all this other stuff. Yeah. But how do you?
Exactly. There's a few things that I don't think I've ever placed a port in practice. I've never done PD catheters. Never done, VP shunts and all that stuff.
Right.
Yeah, I get it.
Yeah, one of the kind of in a similar vein, you've been on the forefront of a lot of the development of like the robotics in the hernia world and techniques and going through the robotars and things like that. How do when you're in a situation where you have that mindset of get it to the next person who maybe does this all the time? What is the process of thinking that you go through when you're going into kind of a new frontier and you're eventually have to get to where you have to try it on a patient? What's that thought process that you go through?
Yeah, you know, yeah, that's a great question. Given my training in fellowship, we did a lot of different types of hernia repairs, especially open. Laparoscopically, we were doing IPOM bridges, essentially transvaginal sutures, circumferential tacks. But I felt very facile with the laparoscope. I felt very comfortable with the anatomy of the abdominal wall. And when I started, I adopted the robot really with the goal of performing extraperitoneal hernia repair because I
Okay.
was just dissatisfied with intraperitoneal mesh bridging.
Yes.
Um, but I started in a stepwise fashion. My first case, robotic ventral hernia repair that I did, it was IPOM. I didn't even close the defect. I didn't even know that that was possible at
Mm-hmm.
that time. And I did it exactly like I did laparoscopically. And then I started taking the peritoneum down because I remember I was in a case just doing an umbilical hernia, and I was telling my partner, well, if we take down the peritoneum doing an inguinal hernia, it seems like we could do that robotically as well. So from that was born the RTAP ventral hernia repair. And then I started going deeper. I did a lot of open reef stopa
Mm-hmm.
before. So started doing robotic reef stopa. I was familiar with Carbonell's version of the robotic posterior component separation, which fell out of favor. And then I learned PAR. And I said, whenever I was going to do this, that I wanted to mimic pretty much exactly how I would have done it open
Mm-hmm.
with very little variation. Really, the only variation there it was the barb suture.
Mm-hmm.
So I did it exactly the same way every time. It was a stepwise approach. I just didn't jump into, doing complex robotic hernia repair. At that time, there was no international hernia collaboration. There was
Right.
no RSC. There wasn't
Mm-hmm.
much YouTube videos on this. We were kind of faking it till we make it type of
Right.
thing at that time. Um, but always trying to reproduce an operation that had some historical significance, some data behind it of quality outcome. And that was always important for me.
Is that, I guess that, comes to mind when you talk about that. That does give, I guess, a little bit of confidence that if you are robotically able to reproduce an open surgery pretty much note for note, so to speak, that you do kind of have an idea about the outcomes, at least somewhat. It's not like you're just completely throwing caution to the wind and saying, let's see how this goes. You kind of know,
Absolutely.
kind of what, if you do it the same technique, what you can get to open, and
Absolutely.
it should be at least transferable in some ways. Has there been anything
And,
that has there been anything you've done that has proven surprisingly not that way?
uh, not really, to be honest with you. Again, what I was surprised about, I remember my first robotic posterior component separation case. It was a double dock. I called it double dock reef stopa with posterior component separation, and it was based on the Carbonell technique. And it was this lady with a recurrent incisional hernia. It was about 12 centimeters wide. And I remember I was there. I was going. I told the rep, I'm going to dock. I'm going to open the posterior sheath. I'm going to try to dissect in between the transversus and internal oblique, and then I'm going to redock and do something else. And the rep was like, I don't think we can be here. At that time, it wasn't even FDA approved
Right.
for that. And I'm all right, I'll figure it out. Did it on this patient, and I saw her the next morning, and she was like in no pain, like
Mm-hmm.
super happy. And I was like, well, that's interesting. I could probably discharge you. She was on a diet, she was ambulating, she was voiding, she was doing all the things. But I felt there was no way, because my open version of that, they would stay 3 to 5 to 7 days.
Mm-hmm.
And then so I said, okay, let's just wait and watch. We'll watch you for another 24 hours. She did everything even better the next day. And I was like, well, there's no reason to keep you. Even up to now, I've been doing that surgery for over 12 years now. And I'm still surprised at how much you can do no matter the length of the case. Do it minimally invasive. It's amazing how well your patients can do
Mm-hmm.
with these cases.
Yeah.
Um, so, so yeah, and I still do some open stuff as well. That's still a part of my practice, obviously. So you have kind of a natural comparison there. A prospective open versus MIS uh, uh, tablet to deal with, and again, it's been a nice change for sure.
Yeah, we've got to where a majority of our TARs, we're not talking taking down fistulas and things. But
Yeah.
majority of our more straightforward TARs, they go home from PACU. And
Yeah.
the first few times you do that, you're sitting there going, "Boy, I sure hope that I don't get a call at midnight." And there's from a
Yeah.
frantic call from the
Right.
emergency department. But it's one
Yeah.
of those deals where we'd go see them the next morning, and they would look so good. You're going, "I don't really have a reason to keep you." And
Exactly.
and so once we got our multimodal pain regimen really keyed in, that made a huge difference. And then we started also using the liposomal. Local anesthetic kind of
Sure.
uniquely, and that kind of pushed us over the next hump. And so now they do so well that sometimes when we do an open case, we forget that they're going to have as much pain as they do. And
Yeah.
so
Right.
it's kind of surprising, but it's also interesting how as you get the more complex stuff, obviously there's patient selection involved for what's appropriate for robotic and
For
open.
sure.
And something that we've seen, and I don't know if you see it in your practice, is that as you get further and further into that, you end up with more open cases than you would have previously, just because the more and more complex starts to come your way, and you say, this is not
Yeah.
really appropriate.
Yeah, for sure. There's definite, like I was saying, open is still a big part of my practice as well. That's really all I deal with. And I don't know if you remember that Life commercial, that guy, that little kid, Mikey.
Yep.
He would eat his cereal, and they would say, "Just give it to Mikey. Mikey eats everything." I
Yeah.
feel kind of like Mikey because I get everything that everybody else doesn't want. Essentially, this side of the Mississippi or my side of the Mississippi. So, yeah, that's my practice. I guess I wasn't careful enough for what I wish for.
Yeah.
Um, because my favorite surgery is the RTAP umbilical hernia repair,
Oh,
and
really?
unfortunately, I don't see those cases anymore. You know.
I will tell you, you talk about that your practice kind of just ends up lending itself to what you get referred.
Yeah.
I really wanted to do head and neck surgery,
Yeah.
and avoid and didn't go to fellowship for it or didn't apply because my wife, who we have, I think, something else in common is that my wife's a physician as well.
Mhm.
We after we got through residency, I didn't know if we were going to survive residency apart as much as we were,
Yeah.
and I was like, I don't think I can go off and do a fellowship. We may not last, and so I wanted to do thyroids. And I think I've been in
Yeah.
practice for 10 years. I've done two. And so now I don't even see
Yeah.
them anymore. And
Yeah.
that was really what I wanted to do. And inguinal hernias scared the crap out of me whenever I was done because I never felt like I really understood the anatomy.
Yeah.
Most of our folks were still doing a lot of them open and they're doing them through these tiny little incisions. And you can't really see
Hmm.
anything. And you're going like, I don't know
Yeah.
what you're looking at. And then you get out
Yeah.
the first time and it's like, I don't have a clue. And now all I do, most of what I do are inguinals, and I have so many inguinal scrotals now. And I'm like,
Mm.
where did all the regular inguinals go? Like
Exactly.
the same
Right.
people are referring to me. I don't know how I don't
Yeah.
get any of the just straightforward 20-minute, everything putting mesh in easy stuff
I
anymore. It's
know.
all a slugfest. But
I
again,
know.
you never want to complain about volume though. So
Yeah.
at least you have a
Hey,
job.
it's a credit. It's a credit to you that you're reference center for getting referred these types of cases. So, and I think that puts you in the unique position to be able to help people that there's not a ton of people out there that can help. So,
Yeah.
that's kind of how I see it. Even though I much prefer doing the easy stuff. You eat what you get served.
Sure.
Um, so
Do you
yeah.
have, even at your level, do you have any cases that you see it on your schedule and then a few nights before you're sitting there thinking about it in the middle of the night?
Oh, all the time. All the time I stew on different cases, even though the palette of approaches that I currently offer isn't large. Yeah, there's definite cases like that. Especially the more complex that you get. It's not only the multiply recurrent nature of their problems; it's their level of comorbidity. Um, yeah, that's one thing I've never been able to not do is stress out about patients.
Yeah.
I still stress. I'm still like on my phone all the time, checking on seeing how they're doing when I go
Yeah.
out of town. That's like the worst. The occasional bounce back and bounce back when you're out of town is
Yep.
is is horrible. But I guess the moment I stop caring about stuff like that is probably the moment that says, I'm probably done
Right.
with this.
Yeah.
So
I think people handle things like complications and bounce backs and stuff. Different people handle it differently. I don't.
yeah,
It takes a huge personal toll on me. Nights and night after night,
huge.
just sitting there laying awake, replaying it over and over, wondering what I could have done differently. And now, now one of the big problems I have with the DV5 is I wasn't recording my cases prior. And now I have the
Hmm.
case like recording at my fingertips at all times. And so now I'm like sitting there
Yeah.
going, could I have done, did I do, I go back like, it's like 3 a.m. and I'm scrolling through like a 3 hour case going
Yeah.
like, did I do that the
Yeah.
way is that as good as it could have been? But what do you have, just the nature of these cases that you do, their complication rates are high. I mean, just by the nature of the case itself, even in the best hands. How do
Hmm.
you, what advice would you give to somebody who has gone through all the steps, is qualified to do the surgery, not in over their head, but is early in their learning curve, and they may not have 100 TARs under their belt, and they do have a complication. How do you handle that? Do you have any advice for those folks?
Yeah, I think that's a great question because one of my things is one of the reasons why I wanted to go to academic surgery at that time, and I felt it was a good time. This may be a long-winded story,
Okay.
at that time it was 2019. And I kept on hearing that residents were not under console; they were bedside assists, exchanging instruments, and I saw that paradigm, and I was going, that's very troubling that a chief resident is now relegated bedside, exchanging instruments and docking the robot, whereas prior to that, they would have either been doing that open or straight stick laparoscopic. So one of the challenges when I was going in is I was going to teach residents how to do. I was going to prove to everybody that residents could be doing these cases, which is part of the reason why I released my resident and I
Hmm.
compilation,
Right.
and disseminated that in through the IHC through YouTube.
Hmm.
But the thing is, I think I could train people how to do the surgery. But what I've learned in the last, 5, 6 years, it all happens in the clinic. It's all about getting patients ready for that surgery. It's
Hmm.
the prehabilitation process, and I think when I was focusing on that, and people always use the generic terms of BMI, smoking, and all that. I don't really have a BMI number. I don't necessarily require you to stop smoking. I do like your diabetes well controlled, but honestly, sometimes I don't even look at that. I think what I've incorporated in my practice is making sure that they're strong enough and fit enough to be able to handle the surgery.
Hmm.
Because most of our patients, whether it's been advised by their physician, they have a hernia, they say, okay, you can't lift a milk carton. Essentially, you can't do anything.
Hmm.
So what happens there, they don't do anything. They're scared of lifting. They're scared of exercising. They think their hernia is going to blow up. So they sit on their couch and they eat, and they actually make their pathology worse because they're getting more obese, which is expediting the progression of their hernia disease. So what I've done, is dispel that myth to them that I don't restrict anybody prior to surgery. I want
Yeah.
you as strong as possible,
Yeah.
and they're happier for it, right? They're happy about the fact that, oh, I can play golf now, or I can go to the gym. And well, yeah,
Right.
what is driving the progression of your hernia is your weight.
Hmm.
That native intra-abdominal pressure caused by a fat intraperitoneal cavity. Um, so get them more fit, get them to lose a lot of weight. So even before I do the surgery, they're already feeling better.
Hmm.
I think that's the secret sauce. So I worry about my residents that are graduating that have the technical skills to execute complex cases, but I'm hoping that they're only with me for 2 months. I'm hoping that they understand that the process, the most important part of the process, and the most important part of the journey is the clinic.
Yep.
Not only preoperatively, but postoperatively, making sure that you follow them, making
Yeah.
sure that you understand how your techniques are working on those patients in long-term follow-up.
Mm-hmm.
It's been the history of hernia repairs that patients are seen 2 weeks and call me if you need me after
Right.
that.
Mm-hmm.
The reality is that there's a complication, which hernia is a lifelong disease. And if there's a complication, they're probably not coming back to you.
Correct.
So what that reinforces in that index surgeon is that they're doing perfect jobs,
Yeah.
potentially doing really bad repairs,
Right.
or picking terrible approaches, or not preparing their patient for surgery. That is what I see,
Mm-hmm.
unfortunately. A lot of the stuff I see starts off with a small umbilical hernia.
Yes.
Failure after failure after failure. All of a sudden, they have a really big, very complex problem.
Mm-hmm.
And and I'm sure you see it in your office, and I tell patients, I'm not saving your life here, right? Yeah, I'm not, you're not a trauma victim after a motor vehicle collision. I'm not
Right.
putting you back together. What we're doing is we want to give them the quality of life that they want,
Mm-hmm.
free of fear of lifting, free of fear of playing with their kids, free of
Yeah.
fear of, or the ability just to tie your shoes or to get out of bed like a
Mm-hmm.
normal person.
Yeah.
Um, Once I understood that, um, that I think that really took my profession to the next level, my practice to the next level. So,
Yeah. No, I think just exactly what you said. When I early in my career, I saw him at 2 weeks. I saw him at 6 weeks, and 6 weeks was mostly just to give him a clearance to go back to normal activities.
yeah.
And then it wasn't until we really started focusing more and more in on our hernia practice that we put in our pathway, which is we see them around 10 to 14 days
Hmm.
after surgery, and then again at 6 weeks, 6 months, a year, and then yearly until 5 years. And
Hmm.
we are a little over 3 years out from that, from some of the earlier people that we have done, and we've recaptured some of the people that we knew that were before that just by them coming in for like a gallbladder or something, and us being like, okay, well, we can get you back
Yeah.
on. But
Hmm.
like you said, has changed the way that I've done things because I've
Yeah.
seen these little primary umbilicals that I closed when doing something that come back at 2 years. And
Yeah.
then thinking, well, I probably need to be, I'm not taking good enough bites, or I'm not that person. I should have, mesh
Yeah.
reinforced instead of just throwing a stitch, or, in those
Yeah.
types of situations, you never know it. And they come back, and the perception, at least a lot of my patients, they go, oh, I just thought that was the way it's supposed to be because you fixed my hernia.
Exactly.
And then, now
Yeah.
they've got this big problem. You're like, how did you not come back and tell me about this?
Yeah.
But, and then the other aspect of what you just said that I think is so critical, I really think that, as surgeons, nobody likes the clinic. I get that. I didn't like it
Yeah.
whenever I was in training either. And
Hate
then
it.
I got out and I realized that that's the game. Like the surgery is dessert. Like clinic is the meal.
Exactly.
And you got to get in there. And it's not just about generating that surgery. It's more about getting to know the patient, setting their expectations appropriately,
Hmm.
all those things. The number of people I see that come in for, an umbilical hernia, and they're not concerned about their hernia. They're concerned about their pannus.
Yeah.
And I'm sitting there
Yeah.
going listen, I understand your concern, but me fixing the hernia is not going to affect that, and so
Exactly.
those types, and that to me is how you have amicable interactions after the repair. Because if they come
Totally.
out and go, oh, listen, I came to you and thought this was going to go away, and you haven't taken the time with them. And
Yeah.
it's a big problem. But I was in practice for all of like 2 weeks before I changed the way I closed port sites on how I'd closed them for the first 5 years of residency. And I came out and I was like, my port sites look like crap. How did nobody ever tell me that this looks so bad? But
Yeah.
yeah,
No, I love the fact that you said it's about setting expectation. It's about understanding what the patient's expectations are, and seeing if that aligns with your expertise and what you
hmm,
could potentially offer,
right,
and making sure that there's a clear understanding there. And that only happens in clinic,
right,
again, like you were saying, there's people that come in with bad hernias but potentially pain from something else,
hmm,
and you're saying, I might fix this hernia but that pain may still
right,
be happening,
hmm,
right? So yeah. That's again, the clinic is so my advice to younger surgeons is that as evil as clinic is, I'm not a fan of clinic either. I don't know if any surgeon is. That is if you're going to do this on a regular basis, you really have to take pride in developing a relationship with your patient and getting them to the point where they're ready for surgery. I'm lucky in the fact that I'm fully an elective surgeon.
Hmm.
I don't take any call. If they show up in the ER, it's unlikely that I'll be their physician if
Hmm.
in the setting of an incarcerated hernia, unless the AC guys refer me that stuff. But um, I can say no, and
Right.
it's okay to do that, right?
Hmm.
If they're not following what you want, like the biggest thing I tell the patients, you have to prove to me you're a willing participant in your hernia,
Right.
in your recovery.
Hmm.
Hernia is a lifelong disease. It's not like a gallbladder. You take out the gallbladder, you never have to worry about that again. Hernias, those can be complicated preoperatively, intraoperatively, and postoperatively till the day they die. And I
Sure.
pretty much tell all patients that. Um, and it's not the expectation that they can't lift or they can't perform activities. That's not going to get their hernia back.
Hmm.
I tell them if your belly gets bigger, you run the risk of your hernia coming back
Hmm.
and or chronic abdominal pain.
Yeah.
So that's another important component of my follow up. I make sure that they're not gaining weight. I make sure that I remind them that this hernia can come back, and if I see a upward trajectory of their weight, with concordant increase in abdominal circumference, I was going, you are at risk.
Yeah.
And I tell them straight up. I tell them if you recur, and I tell this pre if your hernia comes back after I'm done with it, there may be no one in the world that can fix you, and that
Right.
sets you off for a lifetime
Hmm.
of poor quality of life.
Yeah.
Maybe even worse than what they were when they initially saw you.
Yeah. Like I always use the term, like hernias don't come back smaller or easier; they come back bigger and badder.
Yeah,
And when they do, eventually, you can get into that just is not fixable. and
yeah,
and it's
yeah,
funny because eventually at just doing what you do, I'm sure you see that situation much more than the average surgeon. But again, if you're not following, if I have a really bad experience at an auto mechanic and my car fails again immediately, I don't take it back to the same person.
exactly,
you know,
exactly.
and I think that there's just a complete lack of understanding by some folks that yeah, they may look great at 2 and 6 weeks, but at 6 months, all of a sudden they've got really bad abdominal pain because of the way that you've tacked everything in or what have you.
Yeah,
And
yeah,
those types of situations just aren't evident if you're not really treating it more like a chronic disease. And I think that's been one of the big things that's really come into my consciousness over really the past year and a half or so. Like I said, I'm still fairly early in the hernia game as a getting deep into the nitty gritty of it all. But
yeah,
you trained not only residents, but you trained a lot of surgeons, like active
yeah.
practicing surgeons, and you were all over the world and giving lectures and obviously putting out YouTube videos is time consuming. It takes
Yeah,
time with editing and things like that.
for sure.
How did you balance all of that and then balance like having a family and being there for them as well? Like I think that's something that I struggle with at least.
Yeah, another great question, Luke. I remember in my first 5 years of practice, first 2 or 3 years, I was doing close to 1,000 cases a year. That's how busy I was. And I would remember coming home maybe about 3 years after I was done. This was kind of when I started teaching a little bit of robotic surgery. At the time, I would come home to my wife and I was saying, there's only so many people that you can treat, right?
Mhm.
There's my impact in the surgical world was somewhat limited to the patients that I treated.
Mhm.
And then I started thinking, well, if I can train one person and that person trains other people and those other people train other people, the potential impact of that, of which is immeasurable
Mhm.
and infinite. And that was a very appealing thing for me. And at the time, I was in a unique position because, being among the first to embark on this, not only robotic hernia repair, but essentially incorporating robotics into the fabric of general surgery. Uh, um, there was a lot of people that needed to be trained.
Mm-hmm.
So initially, when I started doing this, I started doing case observation late 2012. This is probably 3 months after I adopted the robot, which was nice. I was teaching. It was all community surgeons at the time.
Mm-hmm.
And then I told Intuitive, we're not going to get anywhere until we start training academic surgeons. So I got into the academic world, training some of the heavy hitters in big universities here around the United States. And then when I started doing that, I was going, okay, we need more. I was telling them we need to go international. This was, I remember going to the Intuitive branch in Sunnyvale, and I'm sure you've been there before.
I haven't
There's a
yet.
map. You haven't? There's a
No.
map there, and they have pins of all the installed robots.
Mm-hmm.
And I was looking at that map in the U.S. It's full of pins with all the robots in the U.S. And then you just zoom out a little bit, and there was like no robots there. There's no robots in South America, minimal robots in Europe. And I was going, I guess I was naive at the time, but I was saying, well, that's not really fair that I'm blessed with the technology that I think is good for our patients. I was going, I want everybody to have this potential. They kind of laughed at me saying that just wasn't possible, but that was a big thing for me. I wanted to go international. I wanted to go to Europe. I wanted to train surgeons in Europe. I wanted to go to South America. Uh, um, I wanted to go to Mexico, stuff like that. And that became really important. In terms of the balance, it was tough. I grew up, my dad was a busy anesthesiologist. He did trauma call a lot. He would stay at the hospital all the time. Uh, um, but the times I did spend with my family were like hardcore. It's I have two daughters. When I am home at that time, that relationship is blessed and sacred during that time. They understood. I talked to them all the time about it, and I was saying, I'm doing this for you, but I need to do this for myself as well. And I told that to my wife. I told that to my kids, and they completely got it.
Mm-hmm.
Maybe they don't like seeing me much. Maybe they like it when I leave. I don't know. But they've been very good for it because
Yeah.
they understood the passion. They understood what I was trying to do, and it was nice that I was able to have a small part in that.
Yeah. I think kids, I think especially, are so perceptive, and they can tell. They are much more supportive and much happier with me when I'm doing something that I am fulfilled by.
Hmm.
And there are certain aspects of surgery that just don't fulfill me. I'm not
Yeah.
a guy that enjoys doing certain cases and certain things. And
Hmm.
so, but stuff like having these types of conversations, this is stuff that really fulfills me. And I think I'm a better person for it and a better
Yeah.
father for it. And I think that goes down. And so it becomes a situation where, yes, being present is absolutely important, but also if you're present, but you're not really fulfilled and happy in your role in the world, then it's
Yeah.
kind of it can be a negative. And I think my biggest struggle, and you were talking about it earlier, I'm sitting at home going, that case was tough. Hopefully that person does okay. And I'm pull up Epic, like what's their most recent vital signs? Oh,
Yeah.
their temperature ticked
Yeah.
up 0.2 degrees,
Yeah.
and I was
Right.
like, and they're just wanting to play and interact, and I'm sitting there, a million miles away. So for me, it's
Yeah.
not even necessarily about the amount of time I'm there, but it's like the being able to like compartmentalize enough, and that's where I really struggle still with the
Yeah.
with being a
It, it's
father.
It's providing the quality time and keeping that sacred for sure.
Hmm.
I told them, I'm not ever going to miss a holiday. I will never miss your birthday party. I never missed a soccer game. I almost intentionally avoided going to all the gymnastics meets because those were so painful for me. But I did go to some gymnastic meets of my youngest daughter. Um, yeah. And it was kind of nice, I have the ability to say no to travel, but I make sure it's okay within the framework of my family. So,
Yeah.
but yeah.
Well, what? for the residents and fellows coming out, what's your pitch for why hernia surgery? And then what advice would you give them as far as just a general advice for a career path and how to approach their career?
Yeah, I mean, it's such a super exciting time. What we've seen in these last 10 years is a virtual explosion of different techniques, both open, but especially in MIS. Um, and there's so many different techniques, there's so many different approaches, it's almost impossible to learn them all. I certainly don't do every eponym that's out there. I don't do all the surgeries, I don't do all the approaches, but you have to have some good open approaches. You have to have some good MIS techniques. You have to get really good at those. What that depends on is your volume of cases. I'm a big fan of, you were talking about it before. I think video has really changed the way that we learn how to do surgery. When I was a resident, we would look at my attending would say, okay, go look at this atlas.
Mm-hmm.
But I've always said it's very difficult to translate a 2D, a sketch into the 4D framework of an operating room theater.
Mm-hmm.
Now with video, you can essentially simulate exactly what the residents are going to experience that next day. So I give them homework the night before a case. I said, this is going to be similar to what we're going to be dealing with. You got to watch it. But not only that, it's amazing how much I learned just editing video, whether watching myself. Like you were saying, you watch some of the stuff that you do and you ask, well, why did I do that? Or that was
Mm-hmm.
super inefficient, or that was
Right.
super not elegant,
Mm-hmm.
and doing it. And you get better from it. You learn from that and you do hopefully better the next time. So record video, study hard, prehab your patients, ensure they're ready for it. And if you do that, and if you're good enough, you could thrive in this world of hernia repair. It's like a big thing now. We're embarking on specializing abdominal wall surgery. That was
Mm-hmm.
unheard of,
Right.
10, 15 years ago. It was just a hernia, right?
Right.
But from guys like Professor Henneford, who I
Mm-hmm.
consider the goat of hernia repair, he has made hernias cool.
Right.
He's legitimized that pathology to a very wide range of different surgeons, not only the U.S. but worldwide and globally. It's a very exciting time, uh, um, but technical ability will only get you so far,
Mm-hmm.
right? There's so much more to it than that.
Right. And then I want to get to a more serious question here. Do you think that is it the quality of waves, or is it the fact that clothing is optional that makes Black's Beach the best?
It's so funny because I always North County, San Diego was always a second home for me. My parents have always had a place there. I've been surfing since I was 12 years old. And I remember a time, again, another somewhat long-winded story that I'm sure can be edited out. But I remember I was in high school. I think I was a senior or junior in high school, and my parents went out of town, and I'm going, holy cow, I'm going to have the house all to myself. I'm going to have a huge rager. So I had this really big party. I remember I had 3 kegs here. There's probably 200 people in my parents' house. Cops came. My parents eventually found out, and they were like, all right, that's it. So my punishment was my mom comes up to me. He's like, you have to do summer school. And I'm all, no, right? And I was not a summer school because summers were sacred for me. Yeah,
Uh-huh.
right. And I'm all, no. And she was like, you can either do summer school in Phoenix or summer school in San Diego. So I was all, all right, bye. Well, I left for San Diego, signed up for a physics course at UCSD.
Mhm.
And it was always I would be traveling south to the 101 from Carlsbad to La Jolla, and it was either make a left into campus or make a right to Black's Beach. And my car always gravitated towards the right. I never went to one class in physics. Was forced to drop it very early on. I surfed Black's Beach a lot. That was that's the premier wave in North County, San Diego. So yeah, I know all about that scene.
Yeah, as a
It's a nice way to get rid of tan lines, though.
oh yeah, there you go.
Yeah, yeah,
The clothing optional. Yeah, we
yeah,
as an Okie, I grew up in the Panhandle of Oklahoma, and I went to the beach maybe twice until I was 18, and so my wife and I couples match out of OU down here to Orlando Health, and the first weekend we have off, I'm like, well, let's go to the beach. So we ride over to Cocoa Beach, and we get there, and I'm like, we go up to this little surf shop, and they're like, we rent surfboards. I'm like, let's just learn to surf. And of course, I'm like not in the great shape and nothing like that. And I go out there and I like, hey, I want to rent a surfboard. They're like, dude, there's a tropical storm like by the Caribbean, like it's a red flag day. And I'm like, well, that means the waves are big, right? And they're like, yeah. And so I'm like, okay. So they're like, okay. And I'm like, it's gonna be fine. I was a lifeguard back in the community pool back in like, Oklahoma. So they give me this longboard, and it is like, it weighs like half a pound. It's like just straight up like styrofoam covered in a lacquer. And so I go out there, and I get maybe, I don't know, 20 feet off of the beach and almost drowned in like 3 feet of water, just trying to get this thing. First thing that happens is a wave hits the board and just like smashes me right in the face. And finally I like go back up the beach, like set the board down and lay down. And my wife's looking at me all smug, like,
told you so.
Thought you're the big bad surgeon, thought he could surf.
It's crazy because you know what, you watch them and it makes it look so easy. I've been surfing since I was 12. Took some years off with school and stuff like that. But it's amazing how bad I am, even for doing it for such a long time. Athletically, I was always fairly good. But surfing, if you don't do it a lot, it's very difficult. Not only physically taxing, but technically very difficult. It's probably the hardest sport that I've ever done. That along with golf. But from a physical standpoint, if you really don't do it, it's you can't even get out to the lineup. It's very difficult. But you watch TV, you watch the surfers; they make it look so easy. It's like, oh my God, I can do that, right? Not so much. Not so much.
Well, the last segment we have on this podcast is the hernia hot take. And it's basically you're either unpopular or controversial if you want, or just your prediction for hernia surgery. But do you have your chance for your hernia hot take?
Anything?
Yeah, anything.
I don't know. Maybe prompt me with some I think. One thing I think reimbursed. We're going to lose that at some point. We're certainly not going to get paid more than what we're getting paid now. As history has shown, and I'm sure in your 10 years you've seen it. Reimbursement goes down. At the end of the day, it's not about the reimbursement. It's about getting these patients to the quality of life that they want, and we really have to be able to uh, um, reconcile the fact that. That's just what we do. The harm caused by decreasing reimbursement shouldn't overwhelm the joy and the passion we have for treating our patients. You know, Even though we're on the task force to try to maintain reimbursement at least the way it is currently, that's probably a losing proposition, and I'm okay with that. Right, I don't need to be a multimillionaire. That's if I wanted to do that, I'd probably do something else. For the young people coming into the field, don't do it for the money. It's just not there. It's just not worth it. I tell that to my daughters all the time. It's certainly not what it used to be like when my dad was around. That was kind of the heydays. It will never return to that, and you have to acknowledge that. And if it's still the field that you want to go into, those are probably self-selecting some of the best, hopefully.
That's fantastic insight. I very much appreciate you coming on. It's been a great conversation, a lot of fun. I'll have to do it again sometime. But
yeah, super fun.
I appreciate it. And we will, with that, we'll wrap up another episode of the Hernia Gods podcast. This is Luke signing off. Thanks.
Awesome. Thanks, Luke.